Welcome to the webinar, Managed Care Implications for CVD Management, Overcoming Access Barriers to Optimal Anticoagulation Treatment for AF-Related Stroke and VTE. My name is Bill Cardarelli, and I will be one of your presenters. It's also my pleasure to have Dr. Christopher Granger from Duke University Medical Center in Durham, North Carolina, as my co-presenters. This slide shows our disclosures. This next slide shows the learning objectives. Each of us will provide a brief overview of the topics that we plan to cover. In my case, I will be speaking to the first, second, and fourth of the learning objectives on this page. So let's begin. Atrial fibrillation is a major public health issue in the United States. Estimates range from 2 to 6 million people have been diagnosed with AFib. It's more prevalent in white Americans than African Americans. It's more common in people over the age of 65 than younger populations. A major complication of AFib is stroke. Patients with untreated AFib are at a 4 to 5-fold increased risk of stroke compared to those without this condition. The prevalence of AFib will grow dramatically in the coming decades as the elderly population increases. Projected data from the cross-sectional Atrial trial, which was a study of 17,974 adults who were enrolled in a healthcare organization in California in 1996 and 1997, have suggested that the number of Americans with AFib will increase to more than 5.6 million during the next 50 years. More recent analysis from the Mayo Clinic suggests that the number of patients diagnosed by year 2050 could actually be 12.5 million or perhaps even higher. As you can see on this next slide, atrial fibrillation is also commonly associated with other cardiovascular disorders. This has a negative effect on prognosis and is associated with larger medical expenses. There's a 4 to 5-fold increase in the risk of stroke in patients diagnosed with atrial fibrillation. These strokes in AFib are more associated with severe ischemic strokes and longer transient ischemic attacks than emboli from carotid disease. The relationship was illustrated in a report comparing ischemic brain events in patients with AFib and those with carotid disease in 2 major trials. In addition to causing symptomatic stroke with major deficits, AFib is also associated with silent cerebral infarctions and TIAs. The presence of other comorbidities can adversely affect the number of treatment options available to treat atrial fibrillation and those comorbidities. This next slide shows the costs of treating atrial fibrillation. Bear in mind that what I'm showing you here are 2005 costs. Obviously, 2017 costs are much higher. As you can see, the costs on this page are split out between direct and inpatient, direct outpatient, and pharmacotherapy. A different study performed in 2010 placed the direct cost at $73.7 billion, with the mean lifetime cost of ischemic stroke at $143,048. This clearly highlights the need to treat AFib promptly and assess the need for anticoagulation therapy. The major cost driver for AFib is hospital admission, usually as the result of an emergency room visit. Each year, more than 750,000 hospitalizations occur, and this number is expected to continue to rise as the population ages. In addition, the cost per patient is considerably higher in those patients who have AFib compared to those who do not. As you can see on this slide, AFib is a major economic burden. With total costs exceeding $73 billion, stroke and heart failure are the major complications of AFib and are responsible for the majority of the excess costs associated with it. As you would expect, these expenses increase when the patients have comorbidities. This next slide shows the fractal registry. It was a cohort of 973 AFib patients who were followed at 3 to 6 month intervals in an observational registry over a mean 24-month follow-up. Mean annual costs for the 4 groups were $2,372, $3,385, $6,331, and $10,312. AFib therapy's clinical outcomes, both inpatient and outpatient medical resource utilization, were tracked at each follow-up interval. Registry patients were managed primarily with cardioversion and pharmacological therapy. In multivariable analysis controlling for demographic characteristics and baseline cardiac and comorbid conditions, each documented recurrence of AFib was found to increase annual healthcare costs by approximately $1,600. These authors concluded that following initial diagnosis, patients with AFib treated with traditional therapies incur $4,000 to $5,000 in annual direct healthcare costs. Costs are markedly higher in patients with multiple recurrences. So just to summarize, atrial fibrillation is a major public health issue associated with a number of major complications. This presents challenges both economically and medically. Patients with AFib have a much higher risk of hospitalizations and mortality. Patients with AFib are considerably more expensive to treat and suffer from reduced quality of life. The heightened risk of stroke is particularly problematic. The previous standard of care requires frequent monitoring, and while the cost of the drug itself is low, the cost of monitoring and the consequences of suboptimal or no anticoagulation are extreme. Many factors must be considered when choosing a therapy for each patient, and managed care companies must consider the total cost picture when assessing products for formulary inclusion. AFib is an independent risk factor for stroke. In fact, it increases the risk of stroke approximately fivefold. It's estimated that 15% of all strokes in the United States are attributable to AFib, and the proportion increases markedly with age. Additionally, ischemic stroke associated with AFib is often more severe than stroke due to other causes. A retrospective study determined that those with AFib are more likely than those without to be bedridden following a stroke. Finally, asymptomatic or silent AFib is common and may also increase the risk of stroke. I spent quite a bit of time talking about atrial fibrillation and the risk and consequences of stroke, which is the most serious negative consequence of AFib. This slide shows that AFib is also associated with an increased incidence of venous thromboembolism. VTEs are the fifth most common reason for unplanned hospitalization, most of which can be prevented by the proper use of anticoagulants. This next slide highlights the direct and indirect costs of VTE in the U.S. As you can see, there are between 375,000 and 425,000 newly diagnosed VTE cases each year. Not all directly related to AFib, but still a significant number and an equally significant cost. Data shows a direct correlation between AFib and VTE is sparse and seems to suggest that patients with documented VTE are at a higher risk of getting AFib, especially in the first 6 months after a VTE event. That concludes the first part of my presentation. I'll now turn the program over to Dr. Granger for his clinical presentation.
Thank you, Dr. Cardarelli. I will now discuss overcoming barriers to optimal use of anticoagulation for patients with atrial fibrillation. And I'll start out with a case, and this is a real case that I recently dealt with, which is of a 70-year-old woman who has anemia, hypertension, is very active, athletic woman. For 3 months had lots of palpitations and came and saw me. She was on amlodipine 5 milligrams a day, and we got a 48-hour Holter monitor, which showed lots of premature atrial contractions. She had a N-terminal proBNP of 80, which I'll get back to in terms of the importance of that. And then I recommended to her to get an AliveCor monitor, which is the commercially available device which hooks up to smartphones, for which patients can record and then transmit to their doctors their heart rhythm during symptoms. And she had planned to go to Australia on a 2-month cruise. She had Humana insurance in addition to her Medicare. And on a Tuesday afternoon, she emailed this rhythm strip to me that I'll show on the next slide, which shows atrial fibrillation with rapid ventricular response lasting at least 30 seconds. And she said that the symptoms that she had during this recording were quite similar to what she was having for prolonged periods each day. So we had made the diagnosis of paroxysmal atrial fibrillation in a woman with a CHADS-VASc score of 3, which would warrant oral anticoagulation as a Class 1A recommendation in the guidelines to prevent stroke. But this is a challenging situation because she was leaving the next morning before a pharmacy would even open on her cruise to Australia. So here are some questions about what one might do. Reassure her that her risk is low. Tell her to go on to Australia and reassess and begin treatment when she returns in 9 weeks. Start a NOAC, a non-vitamin K oral anticoagulant, hoping that she can afford a 3-month supply. Start Warfarin, which she can definitely afford, but knowing that monitoring it will be a real challenge as she's going on this cruise to Australia. Or start aspirin, which provides some stroke prevention, and then deal with more definitive care later. And the next slide then shows what I did with this patient. And I'll just mention that I think the wrong answers to the question are to either wait until she comes back or to use aspirin. And I'll get back to that. So what I did was got on the phone with her and called her pharmacy and asked them to run a script through their system to see what it would cost to have a 3-month supply of apixaban, knowing that she would not be back until more than 60 days after departing. The pharmacy had the drug, which was good. They ran the insurance numbers, and they told her it would cost $560 out of pocket. She said she didn't have the ability to afford that right now. I asked about other NOACs, rivaroxaban, dabigatran, and edoxaban, and was told that they each would have the same cost. And then I asked, well, what about a 2-month supply? And it turned out that as is often the case, that it wasn't a simple multiplicative issue, that in fact it cost much less to get 2 months, $155. So we prescribed 2 months of apixaban. She could afford that, 5 milligrams twice a day, and metoprolol to use as needed. But I think this is a case that illustrates some of the real challenges in access to oral anticoagulants for atrial fibrillation and the major issues in many situations that we run into when we're prescribing drugs for patients whereby there may be substantial challenges in the patient actually obtaining and taking the medication as prescribed. So the good news is that oral anticoagulation is very effective at preventing stroke. In fact, there are few things in medicine that are this effective at preventing something so important to prevent as stroke. With the historical trials that tested warfarin versus control showing a 64% relative risk reduction in stroke, and then the NOACs compared to warfarin showing an additional 19% relative risk reduction in stroke. So in aggregate, then, there's over a 70% relative risk reduction in stroke with NOACs versus control. So this is an extremely important treatment to be applying systematically and effectively for those patients who will benefit. We also know that the NOACs compared to warfarin have two distinct advantages. One is that compared to warfarin, there's a 50% lower rate of hemorrhagic stroke or intracranial hemorrhage, and then that's accompanied by a reduction in mortality, which is an important illustrator of the net beneficial effect of NOACs compared to warfarin. And then there are other advantages, including lack of need to monitor and ease of use, and lack of dietary restrictions and fewer drug interactions, a number of additional benefits of the NOACs. And the major challenge in use of NOACs is that they are more expensive. But with respect to the broader issue of any type of anticoagulant, warfarin or NOACs, an important issue is that of undertreatment. And it's actually quite alarming to look at what proportion of patients with atrial fibrillation and risk factors for stroke are being anticoagulated. And the aggregate number is about 50% of patients who should be on treatment to prevent stroke related to atrial fibrillation are in fact being treated. And I'll just show you one study from this recent data from U.S. commercially insured patients. This is from the Sentinel data set, which is a group of large insurance companies and providers. This is organized by the FDA. And in the data set that we analyzed from this population, we see that 52% of patients with CHADS-VASc of at least 2, which means that they did have risk factors for stroke which would warrant anticoagulation, in fact are being treated with anticoagulation. And why is this? Why is this highly effective treatment to prevent stroke used in only half of patients? And there have been a number of studies that have looked at this, and a representative one is from the Orbit registry, and it showed that the contraindications that were noted to anticoagulation that prevented its use in patients with risk factors were largely related to perceived risk of bleeding, either prior bleeding, high risk of bleeding, frequent falls and frailty being a major factor, patient refusal, and a lot of times patient refusal being about concern over risk, and then also need for antiplatelet therapy, another factor that comes into play. Let me just step back and ask the question, what do the guidelines say about who should and who should not be treated with which anticoagulants? And now there's alignment of the American guidelines and the ESC guidelines. And what we see is that for patients who have no risk factors for stroke, who are CHADS-VASc of 0, then no antithrombotic therapy should be used. Patients who have a CHADS-VASc of at least 2, then oral anticoagulation should be used with a high class of recommendation and level of evidence. And the European guidelines stress that NOACs being better than vitamin K antagonist or warfarin for those who can afford it. And then for patients who have mechanical valves or mitral stenosis, then vitamin K antagonists should be used, not NOACs. There was one trial, a trial called Realign, which tested dabigatran against warfarin for patients with mechanical valves, and dabigatran was neither safe nor effective. And then for patients who have rheumatic mitral stenosis, there's a much higher risk of stroke in that population, and the NOACs haven't been tested. And it may be that the mechanisms of stroke are a bit different, and therefore vitamin K antagonists should be used also in that population. And I'll just mention another group for which we have little evidence of the balance of efficacy and safety with NOACs is patients who have severe renal impairment, an estimated creatinine clearance less than 25 to 30, where generally warfarin should be the treatment that we use until more data are generated. With respect to these recent guidelines, and the most recent guidelines are those from the European Society of Cardiology published in 2016, there were some important updates compared to previous guidelines. One is to avoid the misleading term non-valvular atrial fibrillation. And the reason that this is important is that about a quarter of patients with atrial fibrillation and risk factors for stroke who were included in the trials that compared NOACs to warfarin actually had moderate or severe valvular abnormalities, and they did just fine being on a NOAC compared to warfarin. And when we talk about valve disease and atrial fibrillation, really what we're talking about is what I had just mentioned, mechanical valves and patients with mitral stenosis. But we should be specific about that and not talk about this general category of valvular or non-valvular atrial fibrillation. Also, there was no recommendation to use bleeding scores as a basis to withhold oral anticoagulation. Now, there was an appropriate recommendation to look for modifiable factors that increase risk of bleeding, like use of aspirin, heavy use of alcohol, INR out of range, for example. But the reason that this recommendation was removed from the guidelines is that generally patients who are at higher risk of bleeding are also at high risk of stroke. And then the concern over risk of bleeding is all too often used as a reason to withhold anticoagulation, which then results in the occurrence of preventable stroke. So focus on the stroke risk, focus on factors that can be modified to reduce the bleeding risk, but make sure that patients are anticoagulated who are at high risk of stroke. Thirdly, NOACs were preferred over warfarin at a 2A level of recommendation. NOACs are clearly better than warfarin, but again, the problem is that they're more expensive. So for some patients, they're simply not going to be an option. And then warfarin is an excellent treatment, especially for those where NOACs are not affordable. And finally, and really importantly, aspirin is noted to have a class 3 level of evidence A recommendation. In other words, do not use aspirin to prevent stroke in atrial fibrillation because it's not effective and in fact it's harmful. And all too often, the misperception of the benefit of aspirin has been a reason to withhold anticoagulation and results in preventable strokes occurring. Let me do something that's a bit provocative, but I think makes an important point. And this is something that Chris Diener and I published some years ago, asking the question, if we already had NOACs, how would warfarin look compared to NOACs? So compared to NOACs, warfarin would result in a 10 to 50% increased risk of stroke, 2 to 3 times the rate of intracranial hemorrhage, as much as a third higher rate of major bleeding, at least, for example, based on apixaban, requirement for monthly monitoring to adjust the dose, falling out of the anticoagulation target range probably about half the time in general practice, many food and drug interactions, and a 10% significant increase in mortality. So looking at this list of comparative features, of course one would not use warfarin for a patient who is a good candidate and could afford a NOAC. I'd mentioned, but I'll just highlight again, that this misperception of the effectiveness of aspirin is one of the factors that seems to relate to underuse of anticoagulation in atrial fibrillation. This is a manuscript that Ben Friedman, Bernard Gersh, Greg Lipp put together that highlighted that the benefits of aspirin really came from one subgroup of one trial, the SPAF-1 trial, and that even then the effect was modest and it seemed to be restricted to younger patients, not older patients. So basically, don't use aspirin to prevent stroke in atrial fibrillation. And another important finding that supports that concept is the trial that compared apixaban versus aspirin, the AVERROES trial. This is a trial that took 5,000 patients deemed not to be candidates for warfarin therapy and were randomized to aspirin or apixaban. And there was a substantially lower rate of stroke with apixaban, and importantly, comparable rates of bleeding, slightly higher, but not substantially higher rates of major bleeding. And in fact, there were numerically fewer intracranial hemorrhages with apixaban than aspirin. So why use aspirin then when you have something that's about as safe and much more effective for prevention of stroke? Again, one reason might be cost, but other than that, one should clearly be using oral anticoagulation. Another important opportunity to improve the care of patients with atrial fibrillation is avoiding aspirin for most patients who are already on an anticoagulant who don't have a clear indication for aspirin. And what do I mean by a clear indication? I mean, for example, recent acute MI or recent coronary stents. Even for patients with established coronary disease, if they've been perfectly stable for more than a year, most of us now are suggesting that we avoid aspirin. And part of the reason for that is that anticoagulation, especially warfarin or the 10A inhibitors, are actually quite effective at preventing myocardial infarction for patients who have coronary artery disease. And therefore, you're already getting an effect that's similar to aspirin when you use an anticoagulant. Adding aspirin to the anticoagulant, as has been shown in many data sets, and I'll just show here one of those, the data from the RELY trial, shows that there's about a 50% increased risk of bleeding when adding aspirin to either warfarin or NOAC. So generally, a good way to reduce the risk of bleeding when one is using an anticoagulant is to avoid aspirin. I'll also mention avoiding nonsteroidal anti-inflammatory agents is another important opportunity to reduce risk. Another issue that comes up often is the issue of frailty. And one of the manifestations of frailty is falling. And we know that the elderly who fall are a group that's at high risk for fractures, for general medical decline. So an important question is, how about patients who fall and have atrial fibrillation? Should they be treated with anticoagulants, or are they simply too high risk for trauma, for hitting their heads, and for therefore intracranial hemorrhage? And this was addressed in a study that was published some years ago in 1999 in Archives of Internal Medicine. It was a carefully conducted study. I don't think the results are necessarily precise, but what this study did is it did a Markov decision analysis model, and it found that a person would have to fall 295 times a year for warfarin not to have greater net benefit than no treatment for patients with atrial fibrillation at risk of stroke. So at least what this does is it's strongly supportive of the idea that if a person falls even a couple of times a year or a few times a year and they're not hitting their head, that person should be anticoagulated to prevent stroke. And then on top of that, that was for warfarin. It turns out the NOACs, not only do they have less intracranial hemorrhage, but they have less traumatic intracranial hemorrhage. And when we've looked at this issue in the Aristotle trial data set, for example, about 5% of patients had fallen in the year before they were enrolled. And we saw that these patients did particularly well with apixaban versus warfarin. In fact, for example, of the patients who were on warfarin, 5 of them had a subdural hematoma, those who'd had falling in the last year, whereas 0 of the patients on apixaban had a subdural hematoma. And we see similar data from the ENGAGE trial with edoxaban, also safer, much safer to use edoxaban than warfarin for patients at risk of falls. So this is a population where using NOACs may be particularly advantageous. Intracranial hemorrhage certainly is the most feared complication from anticoagulation for patients with atrial fibrillation. And one of the important findings that I think needs to be reemphasized, that has been reported before, but we've also looked at this in a contemporary population in the Aristotle trial, is the fact that for patients who have intracranial hemorrhage, the vast majority of the time their INR just before their intracranial hemorrhage was actually not elevated. So an average of 2 weeks before intracranial hemorrhage for patients on warfarin in Aristotle, 78% had an INR that was less than 3. So with warfarin, one cannot eliminate or even substantially modulate the risk of intracranial hemorrhage by assuring that the INR is in the target range. Other factors that were important predictors included being in Asia. This is an interesting issue. For some reason, Asians, or at least people in Asia, has a substantially higher risk of intracranial hemorrhage than other parts of the world. And here again, aspirin treatment. Aspirin, in addition to anticoagulation, was associated with about a 40% higher risk of intracranial hemorrhage. Another reason to avoid aspirin unless there's a clear indication. The most common type of bleeding for patients on anticoagulation is GI bleeding. And this is a type of bleeding where the NOACs do not offer an advantage over warfarin. In fact, as a group of drugs, the NOACs have more GI bleeding than does warfarin, with the exception being apixaban, where there were comparable rates of GI bleeding. And the reasons for this are not clear, but they may relate to the fact that each of these drugs is metabolized or eliminated, some through the P-glycoprotein pathway, and that's a transporter that pumps active drug into the lumen of the intestine. But in any case, this fact that GI bleeding is if anything, more common with NOACs should make us especially aware and attentive to doing things to lower risk of GI bleeding, including avoiding aspirin and nonsteroidals, using a proton pump inhibitor, maybe for all of the elderly, but certainly for patients who've had a prior history of GI bleeding and are put on anticoagulants. I'm going to finish my discussion with an observation that I think is really important, and this is supported by the results of an implementation trial which we recently completed and published in the Lancet. This is a trial called Impact AF. We went to 5 middle-income countries and we randomized centers to control or to an intervention that was designed to address the barriers, many of which I've just gone over in this presentation. So, for example, to work with each of these centers and make sure that anytime one of their patients is on aspirin and not an anticoagulant, that the healthcare providers at that clinic would address whether that patient could be switched to an anticoagulant. And a number of other interventions included materials to help educate patients and patients' families, as well as healthcare providers about which patients should be treated and how to use anticoagulants safely. And then we also provided feedback. So each of the centers got a list of patients who were and were not being treated, and each of the patients not being treated was reviewed carefully to look for opportunities to improve care. And the primary results of our study was that we were able to substantially increase by an absolute 9% the proportion of patients from baseline to 1 year in the intervention group compared to the control group who was on oral anticoagulants, and this was a highly statistically significant benefit. And importantly, it was also associated with a reduction in stroke, and perhaps not surprisingly, knowing that if we can use anticoagulation better and more safely, will more effectively reduce stroke. And the other important finding from this study is that about half of patients who were not being treated with this intervention could be put on an oral anticoagulant and stay on it over the course of that year. And I think this is, in a sense, a call to action. It really suggests that we need to be, in our own practices, reviewing who is being treated, who's not being treated, and then having a systematic and deliberative strategy to get patients treated. So I'll just go back then to the patient who I presented earlier, who had risk factors for stroke and was diagnosed with paroxysmal atrial fibrillation. And I'll reiterate that the appropriate treatment here is to get this patient treated, but not only to prescribe the drug, but to address the barriers that occur between the prescription itself and the patient obtaining the drug, taking the drug, and staying on the drug. Because each of those steps is critically important for our goal of preventing stroke. And I'll just summarize with this final slide that oral anticoagulation is used in only about half of patients with atrial fibrillation and risk factors for stroke, that the NOACs are better than warfarin, but that they are much more expensive, and some patients are simply not going to be able to afford them. And then warfarin, especially when carefully used, is an excellent treatment. The main barriers to oral anticoagulation are concerns over bleeding risk, misperceptions of the benefit of aspirin, and cost and access. And each of these can be overcome with a deliberate and careful approach. And it is possible to cut the underuse of oral anticoagulants in half with implementation programs that include focused education, audit, and feedback. And there are very few things that are more important in what we do in internal medicine and cardiology than more effectively preventing stroke for patients with atrial fibrillation. And this concludes my portion of the presentation, and I'm now pleased to turn it back over to Dr. Cardarelli.
Thank you, Dr. Granger. Vitamin K antagonists such as warfarin have been successfully used for many years to provide prophylaxis against stroke in AFib patients. While effective, warfarin is associated with a number of limitations, numerous drug and food interactions, and has a narrow therapeutic range requiring frequent INR monitoring and dose adjustments. As a result, there is considerable variability in the amount of time spent within the therapeutic range. This exposes patients to the risk of stroke when the levels are too low and bleeding when they're too high. The use of aspirin at best provides modest benefit and really isn't used in AFib. More recently, newer anticoagulants have been developed to reduce the risk of stroke in patients with AFib. The advantages and disadvantages of warfarin are shown on this slide. For years, warfarin has been the gold standard in oral anticoagulants. While it is inexpensive, the level of resource necessary to support patients can be extensive. Self-monitoring tactics have been studied, but the great majority of patients require regular testing either at the primary care facility or a dedicated anticoagulation clinic. It does have one major advantage. It's easy and inexpensive to reverse. The newer direct oral anticoagulants have been extensively studied. In every instance, the newer agents have compared favorably to warfarin. This chart summarizes the agents, comparators, and the study results. The relationship between health plan and physician is delicate. Doctors resent insurer oversight, viewing it as an intrusion into the sacred physician-patient relationship. Some health plans now want to convince doctors that the plan's efforts are aimed at improving the doctor-patient bond. One way to accomplish this is to use evidence-based guidelines in formulary decision-making. Beyond the use of guidelines by managed care, a well-written guideline serves the physician by providing education and assists them by providing clinical recommendation for primary care physicians to pharmacologically manage atrial fibrillation based on the available evidence. This slide shows the latest American Academy of Family Physicians November 2017 guideline update on the use of anticoagulants in atrial fibrillation. It's important to remember that stroke is the most feared complication of AFib and is the reason why anticoagulation is so important in high-risk patients. AFib patients are twice as likely to suffer a fatal stroke, and patients who do suffer a stroke have a longer hospital stay and a much poorer post-stroke prognosis. As with many chronic conditions, managed care faces several challenges. Using the latest evidence-based guidelines to build cost-effective care strategies mandates that companies understand the impact of newer agents on guidelines. The development of treatment algorithms and protocols to ensure appropriate use of medications and to manage diseases is also an important part of this process. Building benefit designs that address cost, medical literacy, treatment adherence, and promote positive lifestyle changes are essential to a successful program. Finally, the expanded use of medical information technology to provide clinicians with up-to-date information about their patients and streamline the delivery of medical care all have the potential to improve patient outcomes and reduce costs. Comparative effectiveness research is designed to inform healthcare decisions by providing evidence on the effectiveness, benefits, and harms of different treatment options. The evidence is generated from research studies that compare drugs, medical devices, tests, surgeries, or ways to deliver healthcare. There are two ways that this evidence is found. First, researchers look at all the available evidence about the benefits and harms of each choice for different groups of people from existing clinical trials, clinical studies, or other research. These are referred to as research reviews because they are systematic reviews of existing evidence. Or researchers conduct studies that generate new evidence of effectiveness or comparative effectiveness of a test, treatment procedure, or healthcare service from a variety of data sources and methods to conduct timely and relevant research and disseminate the results in a form that quickly usable by clinicians, patients, policy members, health plans, and other payers. Critics of comparative analysis rightfully point out that direct active comparative studies are few and far between. So companies also often look to meta-analysis, which gives information from large trials where the study designs may be completely different from one another. The first step in the evaluation process is the application of pharmacoeconomic principles to the evaluation of any product under consideration. Pharmacoeconomics can be defined as the scientific principle that evaluates the cost-effectiveness of pharmaceutical products, services, and programs. It takes into account the total burden of cost to the healthcare system, its patients, and society as a whole. It looks very closely at the cost of medications, procedures, and tests. Pharmacoeconomic studies serve to guide optimal healthcare resource utilization. There are three types of analysis. Cost-effectiveness studies measures all costs regardless of whether or not they're directly attributable to the outcome under investigation. It's important to economists because it identifies inefficiency and waste. It's used extensively in Medicaid-based economic studies. A cost-effectiveness analysis compares costs of achieving a particular non-monetary objective, such as lives saved or quality of life. It has value in examining different treatments against a preset cost. Lastly, we have cost-effectiveness ratios. This type of cost-utility analysis quantifies the mathematical representation of the analysis. Outputs of this type of analysis are measured in dollars per quality-adjusted life years. This type of cost-utility analysis is quite controversial, and several European agencies have attempted to use strict interpretations of this analysis in determining coverage of medications, particularly in the United Kingdom. Specifically in atrial fibrillation, there are several entities that contribute to the burden of cost. These include the cost to the healthcare system, out-of-pocket cost to the patient, cost to employers in terms of missed work, and reduced productivity, and finally cost to society as a whole. Managed care organizations use pharmacoeconomic analysis in the context of formulary decision-making and clinical practice guideline development. As with many chronic conditions, managed care faces several challenges. Using the latest evidence-based guidelines to build cost-effective care strategies mandates that companies understand the impact of newer agents on guidelines. The development of treatment algorithms and protocols to ensure appropriate use of medications to manage diseases is also an important part of this process. Building benefit designs that address cost, medical literacy, treatment adherence, and to promote positive lifestyle changes are essential to a successful program. Finally, the expanded use of medical information technology to provide clinicians with up-to-date information about their patients and streamline the delivery of medical care all have the potential to improve patient outcomes and reduce costs. So let's pause now for an audience participation question. What type of economic studies can you rely on to provide enough information to make an informed decision? Choice number 1 is pharmacoeconomic studies. Choice number 2, cost-utility analysis. Choice number 3, budget impact models. And choice number 4, healthcare-related quality of life studies. I'll pause for a brief second while you record your answers. The best answer here is pharmacoeconomic costs represent the actual costs of the organization, health system, and society as a whole. These types of analysis provide the committee with accurate local data. So your correct answer is answer number 1. It is at the intersection of domains of cost and quality where many decisions about medical care and drug therapy finally take place. Many organizations employ an algorithm for formulary decision-making similar to what I've provided here. This algorithm allows for the consideration of products and supports the decision process by organizing the discussion to yield either a yes or no answer to the question about whether or not to add a product to formulary. It also addresses the value of products, appropriate uses, and addresses safety concerns. Managed care organizations can also make decisions based upon this as to whether or not to employ some level of management techniques to it, such as prior authorizations or perhaps step therapies. So in summary, atrial fibrillation is a major cause of ischemic stroke, especially in elderly individuals. There are several well-defined risk factors for stroke in patients with AFib. Oral anticoagulants are highly effective for stroke prevention. Warfarin is cost-effective for atrial fibrillation stroke prevention, particularly when therapeutic INRs are achieved to levels seen in the clinical trials. Significant differences exist between warfarin use in the real world versus randomized controlled trials and modeling using real-world INR control, and patients show warfarin cost-effectiveness to be a little bit less attractive. Newer agents offer efficacy similar to warfarin with less restrictions on diet, much improved ease of use, but their cost and the lack of a reversal agent, with one exception, makes them less attractive options. So that concludes the presentation. I'd like to thank you very much for your attention. Dr. Granger and I look forward to your questions. Good afternoon, and welcome to today's question and answer session. My name is Bill Cottarelli, and I'll be your moderator for this afternoon's session. Joining me is my co-presenter, Dr. Christopher Granger. This webinar is supported by Bristol Myers Squibb and Pfizer Alliance. If you have a question, please feel free to type it into the question box on your screen, and we'd be happy to address it. Our first question today actually comes from our audience, and the question is something that we were actually talking offline about a moment ago, and the question is, what was the reason given that the 2-month versus 3-month supply of apixaban was so significantly lower? So, Dr. Granger, when you were discussing this with the pharmacy, did they give you any reason or any indication as to why it would be?
So, Bill, it's really important, isn't it? And no, they did not know. We asked them, and they did not know. But what they knew is the algorithm that determines the drug price provided them with that information. And I think it points out that it's highly unpredictable and somewhat arbitrary what the prices are that patients have to pay. And it really tells us as healthcare providers that we need to work with patients to understand what the prices are going to be and work with them to find out either ways that they can have the price reduced, that they can afford it, or alternative therapies.
So that's interesting. I have to confess that I, too, am at a bit of a loss. That insurance company that your patient has uses 2 different PBMs to adjudicate pharmacy claims. I'm not exactly certain how they divide their patients, but half of them go to one major PBM, the other half go to a different major PBM. Oftentimes, PBMs will try to incent patients to use mail order for supplies that exceed 30 days. And at first blush, that was the thought that I originally went to, is that maybe that's what this is. And rather than that pharmacy trying to look for some sort of a vacation exception in this case, that they didn't do that. They adjudicated the claim and then just simply told you whatever number popped back up on their screen after they did so. But this is a 2-month versus a 3-month supply. So I honestly have to say that I'm a little bit stumped. But I do want our audience to appreciate and to understand, and I think this is your message as well, that it is really important for both the physicians and the patients to understand what they're paying for and why they're paying for it. And in this case, why the 2-month versus a 3-month supply was so substantially different. You would expect them to be essentially multipliers of one another. So thanks for the question. If anybody ever finds out an answer to that, we'd certainly be interested in hearing that as well. But honestly, have to admit that I'm stumped. So our next question comes from our planning committee. And the question is, what factors should be considered when selecting among the non-vitamin K antagonist oral anticoagulants for anticoagulation therapy? Dr. Granger, would you like to comment on that question?
Sure. I mean, I think there are a number of factors. Let me start out by saying that each of the NOACs or DOACs has advantages over warfarin, and they each have lower rates of intracranial hemorrhage and less interactions with food, and they're easier to take because they don't require monitoring, and they have lower mortality. So I think there are more similarities than differences, but there are some differences. For example, dabigatran 150 milligrams twice a day had the greatest relative risk reduction in ischemic stroke compared to warfarin. Apixaban had the greatest relative risk reduction in bleeding compared to warfarin, and at the same time had lower rates of total stroke and lower rates of mortality. Edoxaban is a once-a-day drug that is quite safe, and rivaroxaban is a once-a-day drug that has strong data as well. So I think, again, there are more similarities than differences. I will say that I think the safety profile of apixaban is especially appealing in some of the high-risk categories, including the elderly, patients who have falls, patients who have renal impairment.
Well, I think it's important for all of us to understand, exactly what those differences are. It's interesting that we use these acronyms, NOAC and DOAC, and we all have different definitions for them. So on the question, NOAC stands for non-vitamin K antagonist oral anticoagulants. I always thought it stood for novel oral anticoagulants, and DOAC, which is actually in the title of this program, is for direct oral antagonist, quote, anticoagulants. So it's interesting just to see how we kind of get a little bit off with all of these acronyms and just a curiosity on my part. To get back to the question, however, if you look at some of these studies, and if you look at the studies for apixaban and rivaroxaban, one of the things that stood out in my mind is at the time that these studies were done, there was a lot of controversy about time in therapeutic range. And back at that time, and we're talking 2010, 2011, there was a widely quoted article published in the Journal of Managed Care Pharmacy that essentially concluded that for those patients who were on warfarin in a community setting, the most successful of those programs kept those patients within that therapeutic range approximately 55% of the time. And that for larger, either academic settings or larger group practices where they had dedicated staff assigned directly to managing anticoagulation, that number could increase dramatically. And as somebody who works for one of those larger organizations, I can say that we have dedicated staff who manage anticoagulation, warfarin, and everything else for that matter. Our time within the therapeutic range for warfarin is somewhere up in the 80s. So I guess part of the consideration is what type of an organization that you're working for, what your capability is in terms of managing warfarin, if you're going to consider, warfarin as a possibility. And there are certainly plenty of patients that, for either economic reasons or for simplicity reasons, might gravitate more towards warfarin than one of these others. You did have a slide within your presentation where you compared warfarin and the NOACs, where you talked about a 10 to 50% increase of stroke, 2 to 3 times increase of intracranial hemorrhage. That's not stuff that I saw in those studies. So I'm just curious as to how you arrived at those conclusions.
So those conclusions are simply taking the randomized trial data and flipping the comparison. So a 30% lower rate of bleeding with apixaban versus warfarin, if you just flip that, the 1.3, then you get it's a greater increased risk of warfarin compared to the NOAC, simply based on the ratio. So it's and the 30 to 50% rate of intracranial hemorrhage is a 2 to 3-fold increased risk of intracranial hemorrhage. So it's simply flipping it. I mean, I completely agree, and I tried to be careful about this, that warfarin is an excellent treatment, especially when used carefully, and therefore we don't want to discourage people from using warfarin if that's the most appropriate choice. But I think it's the most appropriate choice only if there's a really good reason. For example, cost. If someone can afford a NOAC, almost always they're going to be better off with the NOAC than warfarin, unless they have mechanical prosthetic valves, mitral stenosis, severe renal impairment. There are a few situations, but otherwise, for people that can afford it, they generally should be on a NOAC rather than warfarin.
Okay, well, thank you. Our next question, and I think you addressed this in your presentation, but I want to move back to it. Is it still recommended to add aspirin after a stroke for secondary prevention in patients taking anticoagulants for AFib?
So that's a great question. And the answer is that we really don't know. That's the short answer. I would say, and most of the stroke neurologists that I work with who've done the most work with anticoagulation would say that adding aspirin to an anticoagulant is not warranted for stroke prevention. I would say with rare exceptions. What to do if someone comes in, let's say they come in on apixaban at the appropriate dose. Let's say they don't have 2 of 3 reduction criteria. They're on 5 milligrams twice a day of apixaban, and they have a stroke. Then what do? They have an ischemic stroke. Then what do? And I think the first thing you do is you ask, were they adherent to their treatment? Was there another cause of the stroke, other than the typical thromboembolic stroke related to atrial fibrillation, like carotid artery stenosis, for example? And if they were adherent and you don't find another reason, should you just stay on the apixaban or should you switch? For example, if it's, as I said already, if it's a younger patient who's relatively low risk for bleeding, dabigatran 150 twice a day has the greatest relative risk reduction in ischemic stroke of all the treatments. That might be reasonable. But it's also important to state that even though these drugs are very effective, they prevent the vast majority of ischemic strokes. That they don't totally prevent them. And so it's just like if somebody had a myocardial infarction when they were on aspirin, you don't say stop the aspirin. You continue the aspirin because it reduces the risk of stroke even though it doesn't totally eliminate it. So it might also be reasonable to simply stay on the apixaban. But I wouldn't recommend generally adding aspirin. The reason is because we know that will cause about a 50% increase in bleeding and an increase in intracranial hemorrhage. So it's got a lot of bleeding downside, and no one's really shown that it provides additional benefit on top of an anticoagulant.
And there does at least appear to be some suggestion that the use of the NOAC itself provides some level of protection which might make the use of aspirin unnecessary anyways.
Well, for ischemic heart disease events, that's true. Now, that's a little different question, and I would recommend using aspirin along with a NOAC or at least some antiplatelet agent for, at least some period of time after an acute coronary syndrome, for example. Generally, we say a year.
Well, that was our final question for today. Dr. Granger, would you like to offer any closing comments for our audience?
Yeah, I'll just say it's been a real pleasure to be able to present to you. And I think that, the critical message that I tried to portray is that we do have very effective treatments for preventing stroke. And our biggest opportunity now is simply to use those treatments in all eligible patients who have guideline indications for the use of anticoagulation in a safe and consistent way.
Well, thank you. And I, too, would like to thank our audience for taking time out of their busy day to spend this hour with us. I hope that the information that we provided to you, you'll take back to your practices and use it to better help you care for your patients. To receive credit, please log on to www.naccme.com, where you'll be redirected to complete the post-test and the evaluation on the program page, and then you'll be able to print your certificate of credit. This concludes today's session. We thank you very much for joining us.